Hello and good evening. And today I have the incredible pleasure of having with me Dr. Knut Wittkowski from the USA and Germany, who will be sharing with us some really interesting insights into where we are in this pandemic of COVID-19. So here we have, hi Knut, how are you?
Fine, how are you? Thanks for having me.
Wonderful. A real honor to have you here today. And I think people will very quickly realize why you are such an important voice and one that probably has slightly different opinions to the rest of us. So I'll be exploring some of the thoughts on that. But firstly, tell me a little bit about you, Nut. Where are you from?
I was born and raised in Berlin, in Germany, West
Oh,
Berlin at that time. And then I had an academic career starting with my master in biostatistics in Göttingen, the city of Karl Friedrich Gauss. Then I had a PhD in computer science in Stuttgart and Doctor of Science in Medical Biometry, which covers epidemiology and genetics in Tübingen, working with one of the world's leading infectious disease expert, and that is Klaus Dietz, who actually discovered the relationship between the basic reproduction number, a, a term that he coined, and the herd immunity threshold that you need to achieve to get to herd immunity and end an epidemic.
that's a really important point there, Nut. And it's one, since you've mentioned it, we'll probably just explore this a little bit. So, in your time in Germany, you had been working with one of the top epidemiologists in the world, and looking into quite a lot of detail with HIV at that time, wasn't it?
Yes, I was one of the few in Germany at that time who were standing up against fear mongering from politicians and media, who at that time were afraid that HIV would spread in Europe as much as it had been seen spreading in Africa. And our models and insights clearly indicated that there would never be sustained spread of HIV among the Caucasian population. And in
Wow.
fact, it never happened.
And you were willing to stand up with a different perspective at that time. How was that experience?
Well, at that time, it was pretty frightening, but it prepared me for what I'm going through now. So this now is deja vu all over again. It is again that people have their agenda and epidemiologists are not being heard. And so I'm not surprised that there is a lot of resistance against accepting the basic principles of epidemiology as they apply to the epidemic of COVID.
Listen, I mean, I think that this is such an important point and one that you're right on. We haven't been listening to different experts. Has the media and the political world been only listening to people who say what they want to hear?
It is something that happened over, I would say, the last 50 years. When I started my career, it was still that if you had a position at a university, you had your institute funded and you could had a lot of freedom. Nowadays, the university gives you a table and access to the library, and other than that, you have to raise money, and most of that money comes from government institutions like the NIH. And that explains that there is a lot of resistance between people who are still active in the universities, and they are reluctant to criticize the government for fear that they might lose their funding.
That's a very important point, Nut, and one that I don't think that people outside of the academic world can understand how big an issue that is. Is this the kind of thing that can take a young professor down in terms of his progression in his career?
Yes, definitely. And you see that actually, if you know the field, you hear somebody explaining the research, and at some point in time, there is a U-turn being made, and the person will switch over to present the government position, just to make sure that the funding uh, is not impaired or imperiled.
Yeah, I can understand that. Well, so it takes us right in. I think one of the things that I wanted to set the stage on was that you have got a lot of experience with regards to the area of epidemiology. You've also had the experience of challenging status quo, the way that we think. And so hearing your opinion now, when we are in the middle of probably one of the biggest pandemics that we've had, certainly the one that will stand out this century, hearing your voice is important. So I'm going to be asking your opinion, and I am going to try my best to reflect the position that other people would have in understanding or against what you would say. So I guess the first point that we'd want to come to is, based on your experience with epidemiology, have we done the right thing with regards to lockdown? Is that the right approach? It seemed to work in China.
Well, even in China, in Wuhan, people started with isolation and not with the lockdown. So the city of Wuhan was isolated, nobody was allowed to leave. But initially, people could have a life within Wuhan without much of a change. It was only very late in the epidemic, when the infections were essentially over, that there was a lockdown in Wuhan, but didn't have any effect anymore on the epidemic.
Interesting perspective on that. And in terms of, I guess, other countries, some of the Asian countries didn't necessarily do a lockdown either. Is that about the right
I mean,
perspective?
South Korea, for instance, never locked down, and the government was very proud to never have violated the basic principles of a democracy to give people freedom. It only changed when the virus came to Italy, where in the north of Italy, in a population that is the oldest in Europe and the second oldest in the world, suddenly we had a lot of death among the elderly, and that was, given the healthcare system in Italy a bit fragile, was putting a lot of stress on the Italian healthcare system. And so the government started the experiment, something that had never been done before, of a lockdown. And to the surprise of everybody, the people did not revolt. And so it became something that government would see as a new tool that they could use to achieve whatever their goals might be.
Okay, so let's just look at that a minute, because I remember when there was this huge problem in Italy, and I think, yes, I did think initially that lockdown seemed as though it was unlikely to happen, but it did happen, and it did seem to work, because did it not lead to a control of the pandemic in Italy?
We have no evidence that it had any influence on the spread of the disease, maybe slowing it down a bit, but nothing that was easily visible.
Well, I would come from a healthcare perspective, and I would be thinking, and after I listened to a podcast from one of the Italian anesthetists, where they pointed out that they were so overwhelmed with numbers that essentially people were going to die because of lack of resources. Did the Italian government have any option other than to do a lockdown at that point?
Like in most countries, The lockdown came after the fact. So the major load, the number of infections and the major increase in cases had already happened when the lockdowns started. So, and if you start a lockdown after the number of infections has already peaked and is declining already, then the effect of a lockdown is very minor.
When I think about it from, say, the UK experience, certainly the UK did a lockdown, and I remember thinking as well at the time they weren't planning to do one. I personally thought that was a mistake, because I thought that if they allowed the virus to spread, it would certainly overwhelm the system. All I can say from a clinical perspective is that when they did the lockdown, even though London was severely affected, much of the north of the country initially was protected because the virus was not allowed to spread. So in that sense, I would think that the lockdown did seem to help. Any thoughts on that?
As with every epidemic, and now I'm going back to the work of Klaus Dietz, the epidemic ends when a particular proportion, a sufficient proportion of the population is immune.
Mm-hmm.
And you may slow that down a bit, and it takes a bit longer. In the end, you need the same number of people will get infected, and unless you do something else, the same number of people are ending up in hospitals. It just takes a bit more time, and that takes a bit of stress away from the hospitals.
So if we looked at, therefore, countries like, say, Sweden took the perspective of not doing the lockdown and letting the virus spread to achieve herd immunity more quickly. But they have now gone to the position of using a lockdown. Why?
Not really.
Mm-hmm.
They're not doing a lockdown. They have started to have some restrictions.
Mm-hmm.
But compared to what other countries have done, even what they are doing now is very little.
And so one of the arguments could be, and I remember thinking this at the time when they were using Sweden as an example, I thought that with the Swedish death rate being almost 10 times that of its neighboring countries, was it justified to let that happen, considering that some of these other countries used a lockdown, have largely controlled the virus, and haven't had as much deaths?
Okay, there are two things. Sweden has acknowledged, and that's a big difference to the United States, that they acknowledged it, that they should have isolated the nursing homes.
Ah, yes.
So they left the nursing homes open, as did the United States, and that led to a lot of people dying in these nursing homes. The other thing is Sweden and Finland, for instance, are very different. Sweden is a highly industrialized country. Finland is not. And for instance, if you want to get to Finland, the only way to get to Finland by car or train is through Sweden. So Sweden is exposed to a lot more foreigners coming in, a lot more diseases, has a very different culture. So it's not necessarily fair to compare Sweden directly to Finland.
Yes, good point. Good point. Yes,
or even Norway.
Yes, certainly accept that. So, I mean, in terms of where we are then now, would you therefore think that, say, for instance, the US, which still hasn't imposed a formal lockdown, even though some states are slightly different than others, are they doing the right thing?
No. And it's very, so I said, I could understand that people were afraid in March last year, a year ago, given the experience of what they had seen in Italy. But we know that on April the 17th, Robert Redfield, the director of the CDC, presented data from the ILI-net, the Infectious Disease Notification Network of the American hospitals. And it showed that there were 3 epidemics, one influenza B in December, one influenza A in early February, one COVID in March. And the third epidemic was not worse than the other 2 epidemics that we just had. And that it was, at least in the epicenter at that point in time, which was the Northeast and New York in particular, the epidemic had already, the number of new infections was already down, way down. So there was no more risk that the hospital system might get overwhelmed. It never got overwhelmed. There's a problem here or there once in a while, but there was never the entire healthcare system being under a threat. So one could have reopened as it was originally proposed and promised. One could have reopened the country 3-4 weeks later after the lockdown and say, well, we erred on the side of caution, and now we can go back and live a life.
Now, here's an interesting question from Professor Asdera. He said in New Zealand and Australia, they have used the lockdown approach quite effectively, and it does seem as though it has worked. Any thoughts on that?
It's very difficult to compare, as with Sweden and its neighbors, compare, for instance, the United States with New Zealand. I think these experiences are overinterpreted. And I don't think that the Australian people are that happy with what happened. The lockdowns in Australia, as far as I know, were draconian and not well liked by the people.
Yes, quite true. So, I mean, I understand the different perspective, and I appreciate, and I guess we're at a time now where we need, I guess, to look carefully at what we do next. And so therefore, certainly looking at our approach to lockdown is critical. But here is the question that comes beyond it. When we look at the experience in, say, Israel, which has the combination of lockdown and the mass vaccination, what are your thoughts as to how we can get out of this pandemic?
I don't see much of a difference between Israel and Lebanon, where Israel has now vaccinated virtually all of their high-risk population, and Lebanon has not vaccinated a single person. And I don't see much of a difference between the epidemics in these 2 neighboring countries. So we don't have good evidence that the vaccines are working. We know that in South Africa, the government has stopped at least using one of the vaccines because it was clearly not working. So what we are seeing is what you would expect with a respiratory disease epidemic, where we have a virus that's mutating very fast, or at least fast enough. We now have the data showing that it takes about 80 days or maybe 3 months for a virus to escape and develop strains that can spread as if they were a totally new virus and there were no immunity in the population. And on the other hand, AstraZeneca just announced that they are going to develop a new vaccine, and they hope that it's going to be ready in the fall after 9 months. So the virus will have 3 times the chance to escape before the new virus is there, and that will be modeled after the viruses are on, the new vaccine is there, that will be modeled after the viruses that we have now. So I think this looks very much like the situation that we have with influenza, that the vaccines are always coming too late and are never a good fit for the virus that's actually spreading. So the very hope that a vaccine would actually be the silver bullet that would allow us to open up again seems to be not realistic. In fact, it's very strange when we think of masks. The same people who said that first we shouldn't wear masks, then they said, well, we should wear masks because there were a huge study done in 2 hairdressers in Missouri who happened not to infect other people while wearing masks. And so now we should wear our masks until we have a vaccine. And now that we have a vaccine, the same politicians or the same politician tells us that we should wear 2 masks in addition to having a vaccine. So somehow the whole strategy seems to be not working too well.
I can certainly accept that. Here's a question from Priyal about the RNA vaccine. Isn't it easy to modify and keep a step ahead?
Well, with whatever we do, we don't know what these antibodies do to our system. So we have to do safety testing of new antibodies to make sure that we don't create autoimmunity, for instance. And safety testing is time consuming. So even with a technology that would allow us to technically make a new vaccine relatively soon, to make sure that that vaccine is safe, and in particular safer than the disease, which is not one of the major diseases, is a challenge.
Yes, no, I can certainly understand that. And because as we look at the strategies that are being employed, again, Professor Asdera made the point, are you better off in the US with the way that the strategy has been approached without the lockdown?
Okay, lockdowns have 2 downsides. The first is, if you are, well, let's start with what we should do. We should help the vulnerable people to self-isolate and give them masks and everything that they need, taxi rides and delivery of food and medication and laundry and whatever they need, while the virus is spreading among the low-risk people until we are at the point where 50% of the population are immune, 20%, half of them had already immunity from previous coronavirus infections. And then the epidemic ends. Now, this is the relationship between the basic reproduction number and the herd immunity threshold. So, however, if everybody is doing the same thing, if everybody is isolating, masking, mitigating, then the vulnerable would not have the advantage anymore that they need to be protected. So if everybody is doing the same thing, the virus will spread among all subpopulations at the same rate. And so many more of the vulnerable will become infected, and then many of them will die. So universal mitigation is a very effective strategy to increase the number of deaths in the population.
Interesting point. Now, well, let me throw out the question that I've wondered about, which I have no idea as an epidemiologist, is that we do know that the under 40s are at lowest risk for severe disease, especially children. Would it be a reasonable strategy, therefore, to effectively put them all together, let them get COVID, and therefore largely become immune, and you've taken out a good 40% of your population with herd immunity? Is that an unreasonable concept?
I would phrase it slightly differently. I don't want to infect children. However, going to school and having the social experience is extremely important for children. And if they should get infected naturally in the course of this type of epidemic, we know that they would at worst have a runny nose for a day or two. And otherwise, there are very, very few children who would have any severe effect. And therefore, it would, if our strategy is to reduce the number of deaths, then we should accept that the virus is spreading among the low-risk population at the natural rate, while allowing the vulnerable populations to self-isolate.
And in terms of that long term, therefore, because even with the speed of vaccination, as you've said, we're still not seeming to mitigate deaths. Are we going to come to a point where we just need to accept that this is going to wipe out a significant proportion of the vulnerable population?
No, we should protect the vulnerable, and then they will not be wiped off. If the US had done the same thing that South Korea did with nursing homes, and that is really closing the nursing homes and asking the staff to stay there for 24 hours, never to leave, then we might have had something similar to South Korea, where there were 500 deaths during the first 6 months or so of the epidemic in a population of 50 million. So protecting those who are vulnerable is very important. But if you ask everybody to mitigate, you are actually making that protection less effective. So that is
here's a good question. Is there the possibility that mutations which increase infectivity may also be accompanied by those who also attenuate the severity of the virus?
Okay, in a normal epidemic, a virus stays for 6 weeks, maybe a bit longer in a larger country, and then is eradicated or eliminated by herd immunity. This is what we have seen twice with influenza B and influenza A in the last season, and what was prevented from happening by the lockdowns that are flattening the curve. And that brings us to the second point where lockdowns are counterproductive. We now have the experimental studies that were done. It takes about 80 days, maybe 3 months, for a virus to escape immunity. And if we give the virus enough time to have these successive mutations that eventually lead to a strain that is resistant to all of the antibodies that have been developed, then we have a new epidemic, and it spreads as if the other epidemic had never been there. So even though for a virologist or a clinician, they say, well, this is the same type of virus or it's the same type of disease, from an epidemiologist, it's a totally different thing. And that's what we have seen. We saw one epidemic that in the United States ended in September in the South, and much earlier in the Northeast. And then suddenly the resistant strains that were incubated in Spain and France came to the United States and started a new epidemic. And now, a month or two later, we have the strains coming from South Africa and Kent and some other places. And we have yet another epidemic. And if we continue to have lockdowns, even with vaccination, we are incubating a new strain of a virus for a new epidemic with every lockdown.
I understand.
And it will never end.
Yeah, it will never end. So in terms of, therefore, when we think about the impact, one of the questions from a clinical point of view is that we recognize that whilst we're only speaking about mortality with the virus, in the older age groups, there is quite significant morbidity, which means that even though people don't die, they get significant lung damage, they get significant heart or kidney damage. That could be huge cost to economies if that.
So one thing is, that's why we should allow the vulnerable to self-isolate, so that fewer of them get infected than would get infected with universal mitigation. The other thing is we have to think of other strategies than vaccines to protect them. Vaccines do not prevent infection. Vaccines prevent illness. They reduce the severity of the illness by preparing the immune system so the immune system has antibodies to act very fast before the virus can replicate for the whole incubation period of 5 days or so. And then you would have lots of cells that are infected, get killed by the immune system. You have a huge wound, and this is what's causing the problems. So if the idea is to reduce, of a vaccine is to reduce the number of cells that get infected and therefore the disease severity. Now, something, and now I'm talking a bit pro bono, something I have been working on is we got there starting with cancer and then with neurodegenerative diseases. We identified high levels of endocytosis as a common problem in these age-related diseases.
Hold on,
endocytosis.
Pause a minute. I want you to explain what you mean when you say endocytosis.
Yes, and endocytosis is the process by which cells take up things. Now, viruses don't live. So they have to hijack that process of intake so that the cells are actively endocytosing, taking into the cell the virus. And we found it's very safe strategy to reduce endocytosis to the levels that you would have with intermittent fasting, which is actually known to be effective against virus diseases. So we can give the benefit of intermittent fasting to people and allow them to prepare for becoming infected so that the infection would be much milder. And at the same time, reducing endocytosis also reduces the risk of comorbidities. We were talking about some of those. And that means that the body is more capable to deal with whatever wound the immune system has created. So is we're this reducing the wound, we're improving the ability of the body to deal with it, and that means we have reduced the risk of severe disease and death. And so we have something that's a very mild flu, and we could deal with it like with other mild flus.
So is this something, therefore, that works in all viral infections, or is this specific for COVID?
It works with all enveloped viruses. So it works with all viruses that need that same mechanism of endocytosis.
Which is
with COVID in particular, it works with all strains of COVID because we are not attenuating the virus. We're attenuating the support that our cells give to the virus. And that support our cells give to the virus is the same for all sorts of viruses. And therefore, we would not have the problem of resistance developing.
So what
would work with every virus that's around.
You've mentioned the nebulous product, but what is it?
What cells need to drive endocytosis are phospholipids in serum. And we are using a type of fiber, a string or a ring of sugar molecules that can collect lipids in serum and then is excreted into urine together with the lipids. So we're reducing the lipids that are available to the level that of lipids that would be available if people would be fasting. But we are not requiring them to fast, so we are not running the risk that people get fewer vitamins and fewer minerals. So they will have their regular food and therefore and also enough energy. And so we would not have the negative effects that can come with fasting.
So you've raised something that I wasn't even thinking about, which is that, are you suggesting that fasting in and of itself has an impact on the ability of the viruses to get into cells?
Fasting reduces the process of endocytosis, and that reduces the rate by which viruses are being replicated. Yes.
Wow. And so what you're saying is, so this product would work alongside, so in effect, we could encourage people to fast as well as taking something. Is this a drug? Is it a natural product?
It's a natural product. It's called a cyclodextrin. Now, typically, cyclodextrins are not being absorbed from the intestine, so they would have to be given intravenously, which is inconvenient. But we found a way by observing that many studies were done with milk or milk fat. And we isolated a component of milk fat that's also a component of coconut oil. And if you take alpha-cyclodextrin and that component of coconut oil together, then that capric acid does the same thing that it does, for instance, with maternal antibodies that are taken in by babies with milk.
Mm-hmm.
It opens the tight junctions between cells in the intestinal wall and allows the larger cyclodextrin to be absorbed.
Wow.
So we have a combination of two GRAS products.
Mm-hmm.
GRAS meaning generally recognized as safe by the FDA, that are actually also GRAS in combination, because alpha-cyclodextrin is GRAS recognized by the FDA as a carrier of fatty acids, and capric acid is a fatty acid.
Wow.
So we have something that is approved by the FDA, and if you added, for instance, 2% to vegetable juice, then you are still within the intended use as per the GRAS application and could bring that to the market within days or maybe 2 or 3 weeks.
Wow.
Without any further trials,
Mm-hmm.
because we already know, we have already the trials showing that both alpha-cyclodextrin and capric acid are reducing or are effective against comorbidities. And in
Mm-hmm.
fact, in Europe, the EFSA, the European equivalent to the FDA, has allowed a health claim that alpha-cyclodextrin can be marketed as a substrate to reduce pre-diabetic condition.
Wow.
And
Wow.
pre-diabetic conditions are one of the conditions that contribute to more severe forms of COVID.
Absolutely. Here's a question from Scott. Again, would you recommend intermittent fasting?
I don't see any problem with it. What one should make sure is that one does not reduce more calories, because especially when you have an infection, your body needs calories, and you shouldn't reduce your vitamins and minerals because they're also necessary. We know that, for instance, vitamin D deficiency has been shown to have a negative impact. So we should make sure that we are not reducing the vitamins and minerals while we do intermittent fasting.
Wow. Listen, I mean, this is wonderful stuff, Knut, because more than ever, I think what we're going to find is that voices who have not been heard before, if we still continue to struggle with the pandemic, will have to be heard now, because we will need alternative solutions in order to get out of the pandemic. And my biggest worry has always been, even if vaccines have been shown to be a silver bullet, it's not going to be accessible to most of the world for the next few years because of just in terms of volumes of distribution and cost. And so we do need very simple strategies that can help to be able to make a difference to countries around the world. So as we wrap up, Knut, tell us what your thoughts are towards the future and where we are likely to go in this pandemic.
I think the politicians need something to replace vaccines as the silver bullet. They would be reluctant to simply remove all the restrictions and just say, let's do nothing.
Mhm.
And that's why I see a potential for interventions that are as safe as this nutritional intervention that I'm proposing, but other people may come up with other things. The basic principle is we need something that is safer than drugs, because you cannot give a drug to somebody who doesn't even have symptoms or is not even affected.
Yes.
So you have to have something that is extremely safe enough to be part of food. And if that will reduce the severity of the disease and reduce illnesses, then we could remove the restrictions and just do what we should have done from the very beginning: leave the schools open, leave the economy open, but help the vulnerable people to self-isolate if they want, and give them all the support that we could. Let them have food delivered, medication delivered, laundry picked up and delivered at no cost for everybody who wants it. Even if somebody would abuse that, this would be peanuts compared to the trillions of dollars the lockdown is costing the country.
Wonderful. Excellently said. Thank you very much, Knut. It has been a great pleasure to speak with you today. I
It was my
wish
pleasure.
you all
Thank you for
success
having me.
with your research and your product. Thank you again.
Thank you.